Good morning, good evening, everyone, wherever you may be. My name is Richard Wamai. I'm one of the co-chairs of the committee, CUGH committee on the global health operations. I've been a member of this committee for quite a while. I think first as a member, perhaps now going about 6 years. As I mentioned, I'm calling in from Nairobi. I'm at home. And we welcome you to this conversation for this webinar today. And yeah, let's have a great rest 2 hours with us with our host speakers. Welcome, and I'll hand it over back to Kari to give a formal introduction to our speakers. So, Kari, over to you. Thank you.
Great. Thank you. I just want to make sure, are we seeing the slides or I need to share again?
Please share again.
Okay.
We're able to see them now.
Okay, thank you. Thank you, Richard. And I'm going to move past this since we talked a little bit about our global health committees. And Today, our main moderators will be Dr. Richard Wamai that we just met, and myself and Dr. Anna Halova from University of Alabama, Birmingham. Our session goals are to talk about strategies navigating geopolitical challenges and understanding the influence of governance in global health systems. Also to look at different specific case studies in which we've applied some of these concepts that we're talking about, and then identify new and innovative strategies. Our panelists that we have here today, we first have Dr. Summer Marion as an assistant professor in the Department of Global Studies at Bentley University, and her research investigates global governance and global health politics, specifically on a focus on transnational actors. And during the COVID pandemic, she contributed to the Pandemics and Borders Project, examining causes and implications of cross-borders measures states implement during infectious disease outbreaks. Her career bridges research and practice, informed by experience as an editor at the Pulitzer Center on crisis reporting, as well as work in policy research and teaching innovation at Harvard University. And Dr. Marion will be our first speaker. Our second speaker will be Dr. Carleen Radix, who is the Assistant Dean of Community Medicine and Global Health at Ross University. She is a public health physician, executive leader, and global health expert in Caribbean region for over 20 years. And she has completed medical school at St. George's University in Grenada and a combined internal medicine and pediatric at Overlook Hospital in Summit, New Jersey, and occupational medicine and environmental health fellowship and MPH at the Environmental and Occupational Health Science Institute. She's held various leadership roles, and she is currently joining us to discuss applications in the Caribbean region. And then our third speaker here, we have Dr. Ahmed Arman Siddiqui, who is the CEO of Grameen Health Tech Limited, and it's a company that is driving the digital transformation of Bangladesh's healthcare ecosystem. Dr. Siddiqui has over 2 decades of expertise in telecommunications, innovations, and business transformation, and is leading the nationwide implementation of a complete healthcare solution, groundbreaking initiative redefining how primary healthcare is delivered and accessed in Bangladesh. And our next speaker here is Dr. David Vanderpool, who is the CEO and founder of Live Beyond. He is also a trauma surgeon and author, and with a specialization in improving maternal and child health care and education for underserved populations. He has over 30 years experience as a trauma surgeon and disaster relief expert. And he has worked his Live Beyond work has gone into Mozambique, Ghana, Honduras, Haiti, Palestine, and India. And he will talk about case studies from some of these some of these locations today. So thank you and welcome. And our first speaker is Dr. Marion. Thank you.
Thank you very much. And thank you all for having me today. It's really a pleasure to join you. As Carrie mentioned, I'm a political scientist. I study global health politics based in Massachusetts in the United States. Today, I'm going to be speaking a little bit about the way that global health institutions cooperated or failed to do so during COVID-19 and what lessons we can take from that in this current moment of crisis for global health. Some estimates indicate that dismantling of USAID alone could cost 14 million lives by 2030. So as we're facing this massive challenge to health and to populations globally, with the developing world bearing the brunt of these changes, institutions are also, of course, scrambling to figure out how to move forward. And so before I dig into some of the trends that I'd like to present that are coming up in these policy discussions in the slides, I thought it would be useful to revisit COVAX and COVID-19 as we're entering this moment of crisis in the wake of a pandemic when we most hope that we might see this type of global crisis spur cooperation, despite the fact that state behavior during COVID might have led us to expect otherwise. So as many of you know, COVID-19 Global Vaccine Access, or COVAX, was a multilateral initiative that spurred over 190 states to join. So this was the largest multilateral cooperative initiative that we saw since the Paris Climate Agreement 5 years prior. So it's really significant in that so many countries decided to sign on to this initiative, which had its stated goals of developing a COVID-19 vaccine and achieving equitable global access to the vaccine. Notably, as a scholar of international cooperation, I have to note COVAX is very interesting because it was spearheaded by two pre-existing public-private partnerships, Gavi and CEPI, alongside WHO. In the absence of many powerful states, we would have expected to see more active in such a large multilateral arrangement. So for 190 countries to sign on, this is really a testament to the integral role of public-private partnerships in global outbreak response. This, caused it to be termed by Katerini Storing and her colleagues a super PPP. And as many of you know, just to review it, COVAX is essentially a risk pooling mechanism for high-income countries to sign on and have access to whatever vaccines were effective first, while also funding access to the rest of the world, to low and middle income countries. Of course, this did not deter wealthy states from securing bilateral deals with pharmaceutical companies and crowding low and middle income countries out of the market. Interestingly, also, from the perspective of studying international cooperation, again, unlike most multilateral arrangements, COVAX, when states signed on to COVAX, they weren't all signing on to the same treaty. There was the ability to privately negotiate deals, and so there was less transparency about what states had actually agreed to. Therefore, it was also more difficult to say when states were not complying with the agreement. But we can all certainly agree that 1 year after vaccines were available, when we had seen only 1% of vaccines administered in low and middle income countries, the goal of equity abjectly failed. So the success of COVAX in terms of science and technical advancement, developing a vaccine, contrasted with its failure in terms of equity, mirrors a lot of the strengths and weaknesses of the global health architecture leading up to this moment. In the wake of COVID and the revised international health regulations, as well as the new pandemic accord, which addressed these issues of equity and addressed these issues again of earmarked funding and voluntary contributions, charity-based funding models. These calls for cooperation in the wake of the pandemic have now been met with a new set of challenges in 2025. And so I'd like to move to the next slide and discuss what those challenges look like, the structure of the global health ecosystem, and some of the policy prescriptions that states are discussing as to how to address these challenges moving forward. As you all have all seen, 2025 has been, a terrible year for global health, as we've all experienced. With the U.S. Withdrawing or announcing its withdrawal, being in the process of withdrawing at the second time from the WHO, dismantling of USAID. But the U.S., while it is, previously the largest global health donor who has cut so much funding, is not alone in these funding cuts and was followed, of course, by other major donors. We can go to the next slide. Thank you. So this is just to give you a sense of what's happened in global health financing from 2024 to 2025. I pulled some top-line findings from the Institute for Health Metrics and Evaluation Health Financing Project. So you can see a 21% decline in development assistance for health globally between 2024 and 2025. A 25% decline in development assistance for health for sub-Saharan Africa during the same time period, and an estimated 67% reduction in funding from the US government, which was also followed by cuts from the UK, France, and Germany. In addition, there was 299 times greater spending on health in high-income countries than in low-income countries in 2025. And IHME forecast that these disparities will continue. So this really underscores the growing issue of health equity, which is, again, persistent. This is an old wine in new bottles type of problem, persistent and ongoing issue that the world has been facing for decades, but we're now facing it in the face of many fewer resources. We can go to the next slide, thanks. So what I'd like to focus on for the remainder of my time with you is two major trends that we're seeing in the global health policy space as stakeholders discuss how to address these changes. First, moves toward regionalism, which have been ongoing, but especially have accelerated in the wake of the pandemic and in the wake of these recent changes, as well as this ongoing discussion about horizontal versus vertical integration of global health institutions. And many of you are probably familiar with these terms. What I mean by this is public-private partnerships are primarily funded, draw a lot of funding and are designed, in fact, by non-state actors. They give the Gates Foundation, other actors, board seats and institutional design power that they would not have through a conventional intergovernmental organization, of course, like WHO. And also this gets to increase reliance on earmarked and voluntary funding in global health by and large. And so these vertically integrated models tend to be essentially models of institutions that are reliant on funding earmarked for disease-specific work. They can be extremely useful and nimble in the face of outbreak response, but also tend to detract attention on policy agendas, in particular, often in recipient states, from other issues, perhaps NCDs, maternal and child health, that policymakers there might think need more attention. And so these are two of the conversations that when I was able to attend the World Health Summit in Berlin in October, were really prominent in discussions. And of course, strengthening health systems helps outbreak response too. As we all know, this is not news to anyone. So it's really a question of a question of how can we overcome these political obstacles to getting states to implement the IHR, to getting states to engage in technology transfer and sharing of tools that can help us prepare for future outbreaks as well as address other health challenges. And so to the themes of this panel, I'm going to address each of these one by one, and I'm afraid I don't have great answers for you, but I do have a lot of key questions that I think are coming up in relation to what this means for changes or challenges to equity and sustainability. So we can move to the next slide, please. Thank you. So I wanted to show, whenever I talk about the diversity of actors in global health, I love this figure from an article by Stephen Hoffman and Clark Cole Richard, you actually introduced me to this article long ago. And these data are a bit outdated, but it gives you a sense of how quickly we saw an acceleration in the number of actors in the global health ecosystem from back, in the 1860s when we were seeing the International Sanitary Conferences. So you can see the slow acceleration up to post-World War II, or, around League of Nations Health Section, the founding of the United Nations and WHO. And then the really fast acceleration as the international development institutions and infrastructure grew. And through the 80s, especially with attraction of private investment into the 1990s with greater engagement by philanthropies, NGOs, and other types of actors. We can move to the next slide. Thanks. And so this figure from the same article gives you a sense of what the Global Health Network looked like. This article, again, was published in 2018, and the data are a bit older than that, but it still gives you a good sense of the complexity and range of actors that we see represented in global health networks. And you can see WHO is quite a central node. And, if we go back to 1945, WHO was, and states were the main actors there. But now you can see also civil society organizations and NGOs, professional associations, public-private partnerships, of course, in this greenish color, national governments, other UN system bodies, private industry, academia, philanthropy, and multilateral development banks. So this gives you a sense of the coordination problem that the world is facing. We're dealing still with the institutions that were created in 1945, as well as this proliferation of other actors, public and private. And now with these diminished resources, trying to determine how to move forward. Next slide, please. In terms of moves toward regionalism, this raises some really interesting questions. Of course, we're seeing a lot happening with Africa CDC and increased cooperation in Europe. I think in theory, and the IHR and the current global health regime is sort of founded on the idea that multilateralism is best for provision of global public goods, and the idea that diseases don't respect borders. But we haven't been able to achieve equity that way. So in theory, you would think a multilateral arrangement would be the best way to achieve global equity, but politics matter in health, as we all know, and it hasn't worked. And so I think this raises questions of, as we have seen in some other cases, whether regionalized governance models can exist hand in hand with or better serve these principles of global equity. And in terms of what this means for provision of global public goods, what does it mean for technology transfer and transfer of tools, and how countries are going to cooperate around those types of issues? Similarly, I've heard concerns from practitioners in regions with weaker collaboration, some in South Asia, for example, that the way that multilateral institutions are structured right now, with this diversity of actors, to have access to non-state actors, to philanthropies like Gates and Wellcome, you might need to have a strong regional arrangement. And so if some regions aren't developing the same level of cooperation, there are questions about what that will mean for coordinating amongst these diversity of actors, and whether they'll have the same access to non-state actors who are major players in the global health space. Next slide, please. Similarly to the questions about horizontal and vertical integration, I think, there's pretty broad agreement that charity-based models are no longer working, but we can't rely on them, essentially. But how do we get states to commit to horizontally integrated state-led models? And we also have vertically integrated institutions like the Global Fund and Gavi that are really central to the global health architecture. These institutions were created to put themselves out of business, but they've yet to fulfill their mandates, and they're going through massive funding cuts and reorganizations themselves as they confront this challenge. So I think this also raises a question of whether there's a trade-off between adaptability, like we see in public-private partnerships, and sustainability and horizontal integration of institutions. So when we have more, is there a way to create a more adaptable bureaucracy in these state-led horizontal models? Next slide, please. And so to conclude, I just wanted to share a few themes that I've noticed in policy discourse recently, and also some enduring questions, I think, for what the future will look like. First of all, as I mentioned, this move away from aid and charity-based models will require sustainable political commitments from states. And we've seen time and again that that's very difficult to achieve. So I'm not sure what incentives we need to change to make it happen. Moves toward regionalism must be accompanied by stronger coordination to ensure provision of global public goods, which we're attempting, to do, I think, through some of the new agreements on the table, but it's unclear how those will be implemented. Decreasing redundancies and having fewer, more streamlined global health institutions is extremely painful and difficult, and that's what's happening right now. And then I did also want to mention, all the conversations ongoing about One Health and integrating human, animal, and environmental health and systems-based approaches to governance. And we have so many great case studies of how that can work really well at the local and community levels. But the question of how can that scale that the quadripartite and others have been wrestling with. And one final slide for you, a few questions to leave you with. I think a major question that I've heard stakeholders grappling with, and that we talk about with every reform, is can we actually align on thoughtful and intentional reform? Or will whatever we do be the result of de facto adaptation because no one in the global health space asked for this moment of crisis that we're facing right now? And in terms of implementation, again, is it possible to incentivize sustained political commitment from states? And finally, we're still dealing with many institutions with WHO that, was created 80 years ago, and is an incredibly central actor to global health and will continue to be. But is it possible to design truly adaptable institutions? We've done that to some extent with these vertically integrated public-private partnerships, but there are trade-offs. So how can we balance adaptability with equity moving forward? Thank you.
Thank you, Dr. Marion. I appreciate your presentation and thank you for your thoughtful points. Just moving forward to let everyone know, Dr. Wamai will be fielding questions regarding this topic in the breakout rooms, and so we thank you for your participation. We are going to move on to our next speaker, which is Dr. Carleen Radix, and so I will let you take that away. Thank you.
Thank you so much. So are you hearing me okay? I'll take that as a yes.
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 Okay, great. So I'm going to just spend the next 10 minutes or so coming down to basics. As was introduced, I am a public health physician currently in medical education, and so working across the Caribbean in health system resilience. And so in looking at this topic of blended finance and cross-sector collaborations, I just wanted to sort of review what that means and so that we can think about it as we go into our breakout groups around the changing landscape that we're seeing around sustainability and funding. Next slide, please. Okay, so really, if we're talking about a cross-sector collaboration or blended financing, or we're looking at the pie, and we just saw that chart of the increased number of actors. Really, we're talking about shared resources. And I don't know if you all are familiar with the story of Stone Soup, but basically it's a story of how many persons with limited resources were convinced to put those resources together to create one pot of soup that could feed all. And ideally, this is what we're working towards in terms of sharing resources and keeping equity. Next slide. So broadly, when we talk about cross-sector collaboration, we're talking about government, private sector, nonprofit, civil society, and of course there are many other ranges of actors in the pot. But really talking about the fact that actors coming from different spaces with different goals coming together to have a common outcome. Next, please. So we all know the benefits of cross-sector collaboration. A main benefit, of course, is shared expertise and sharing of different experiences and multiple perspectives. And we're quite aware that the differences bring a rich value to these types of collaborations. Obviously, as we're talking about here, there are shared resources. So the ability for persons to bring different things to the table in terms of concrete resources are clear. Hopefully, we have increased efficiency and effectiveness. Sometimes that is just because we have a dearth of resources. So what's happening now in terms of persons having to consolidate for efficiency, but hopefully we also have increased effectiveness. And with multiple actors, there is increased sustainability. And we can see, we've seen what happens when there's dependence on just one source of funding. And this can improve impact and reach. And I have just a photo there of just a workshop that we had in Barbados with multiple actors. You can see the different logos across the top. But the point is that, next slide, please. This can happen at any scale. So some prerequisites we must have, and it may seem simple, but sometimes we jump to collaboration without having these clear prerequisites in place. There must be a shared goal, there must be alignment, clear expectations, and that's only set by open communications and an understanding of both the strengths and the limitations of the various persons involved. The good thing about cross-sector collaboration is that it's flexibility in scale. So we have all kinds of models, from as much as a small project or a program to large public-private partnerships or multi-stakeholder initiatives and collective impact, for example, towards the Sustainable Development Goals. Next slide, please. So let's take a moment to pivot to blended finance. And disclaimer, I am not a financial expert, so I'm sure we'll have more discussion in the rooms, but this is what my understanding is of blended finance. Is this going to save us? Is this going to save us from all the concerns that we have? So blended finance, as per the World Bank Group, is a strategic approach that combines public and private funding to mobilize private capital flows towards emerging and frontier markets. It aims to attract commercial capital to projects that benefit society while providing financial returns. Another definition speaks of it as catalytic capital to increase private sector investment in sustainable development. So basically, this is giving incentives for private sector to invest with a promise of return on investment. And this can look like first loss capital, so initial capital going in from public or philanthropic sources, guarantees in terms of losses, loans that have better percentage rates or terms, etc. Next slide for me. So what it's not for every situation, right? It's also not a long-term solution. Blended finances is intended to bring the private sector into the market for a sustainable revenue generating activity. It's not private sector philanthropy. So in looking at whether or not it's an appropriate response, we need to know if there's a need. So is there a financial constraint, a high risk in the market, or poor capital investment? If there's revenue potential, so that's key, there must be revenue potential. If there is incentive alignment, and is the size and the cost of what's, is it worth scaling up? And most importantly, what is the capacity to engage in this blended financing? Are we getting the right actors together? And there may be some actors we don't usually bring together to ensure that locally the capacity is there to take advantage of this sort of financing. Next slide, please. So there's some 5 principles here by the OECD, but I wanted to focus on 2 of them, specifically the development rationale, which is clear. So there is that conflict between revenue generation and your development goal. And also I wanted to talk to local context. Too many times, I think when we think of private investors, especially from the global South, we think of external investors coming in, and really understanding the local investment context, local investors who may be better aligned, and bringing them in on the conversation, I think is important when considering this type of finance. Next slide, please. So in healthcare, so in the Caribbean, we've seen blended finance in areas such as climate adaptation, the ocean, the blue economy, as we call it, increasing, and in those kinds of sectors. Where are the opportunities in health? And obviously, if there's a revenue generation potential, there's certain areas that sort of lend themselves to this kind of approach. These include in the delivery of health services, infrastructure and innovation, and then obviously things like devices, diagnostics, pharmaceuticals, and vaccines. Next slide. So in conclusion, I wanted to just tie it back to my own passion, which is around resilience. In the Caribbean region, we're always recovering from one disaster or preparing for the next. And so one article that was put out by the World Bank looked at resilience in terms of 4 types of capacity: anticipatory capacity, absorptive capacity, adaptive capacity, and transformative capacity. And so one of the questions about sustainability as we build cross-sector collaboration and consider blended financing, we must support the development of these capacities to ensure continued sustainability. Thank you so much.
Thank you so much, Dr. Radix. We again will answer some questions after all the speakers. So we'll move on to the next speaker now, which is going to be Dr. Ahmed Arman Siddiqui. So please take it away.
Thank you. Thank you so much. I'm really happy to be here, and I can understand that I'm the one who knows least about health tech here. I'm just a technology evangelist. So I'm really going to talk about innovation and technology in addressing global health challenges. Can we about the limited access to the care? I mean, there's a huge raising non-communicable disease burden, and I started this company 1 year before, and when we had our research and we found out that it's really correlated with the high-income people, and the mortality is really increasing in case of the NCDs and decreasing for the CDs. And then we realized that EMR is extremely, extremely important to actually address these issues of non-communicable disease. And that's how we actually wanted to address this data gap and mainly the weak systems. where we found that the digital health tech innovation could actually add value to actually address this epidemic scenario. So if we move to the next slide, the strategy that we took is about to address the health system inequalities and to focus on telemedicine and virtual care, and of course an equitable health. And through that, what we did was a community-based digital platform. We developed a digital ecosystem. We had AI-driven decision support. Very interestingly, very recently, we didn't put ourselves limited to uh, uh, app only. We also connected with other ecosystems like devices. So the challenge that we have to go, not to able to go beyond the primary care, we tried to address that. And I will give you some case study later. How did we actually come out with the solution? And most importantly, it is important to have interoperability. The name of the platform that we have, his name is CUGH, and it is actually HL7 FHIR compliant platform. So going to the next.
Ahmed, it seems your audio is cutting a little. I would suggest maybe turning your video off. It might help.
Oh, okay. Is it better now?
Yes.
Okay. So if you go to the next slide, this is actually a Bangladesh scenario. The elements of stroke and ischemic heart disease. These are the top two reasons of the non-communicable disease. But some of the elements are really increasing, like COPD, like diabetes. People are not dying anymore from drowning. So that means that improved healthcare measures is required, and the lifestyle which is deteriorating. Bangladesh is a very small country, but very populated, densely populated country, where we have issues of absolutely environmental hazards, pollutions and stuff. And that's where we came out with the tailor-made solution. So if we go to the next slide, what we actually did, we came out, can we go to the next slide, please? Yeah, thank you. So we came out with this 360-degree ecosystem where we not only took care of the primary care, we had connected the secondary care and tertiary care through the remote care modality. Health professional enablement platform. This is the platform. If you go to www.shuki.com, any health professionals can actually, they can opt in and they can actually give the service based on their own financials. It's an open platform. Then same goes to the provider. Is one of the best aggregation model that we can ever think of. Partners we actually assembled together. We had all the health contents, the awareness elements, conditions and disease management. We have our pharmacy solutions, diagnosis solutions, teleconsultations, and we also have e-commerce site. So anyone wants to see an endocrinologist can also buy diabetic strips and machineries if he or she is required. So, and the right hand side is actually the view of the app where you can see, we call it mental wellness, because as you know, in case of the digital health tech and digital healthcare, more or less they come mostly for mental health and also for the taboo diseases. And also the people from the remote areas, they want to use the platform. Interestingly, we have other services like surgery booking, lab on the go. That means the phlebotomist will come to your place and collect the specimen, online pharmacy, e-commerce, pregnancy calendar, caregiver, medical tourism. So this is how the app actually looks. But we are not limited to B2C only. What we tried to do in our case is we wanted to have this whole ecosystem. So if you could go to the next slide, you will see Shukhi app is actually in the middle, but it is complemented by two more apps. One we called a complete hospital management system, and another we call it logistics, inventory, POS, suppliers, and SSK. So SSK stands for Shukhi Sheba Kendro. That means Shukhi. People who can afford phone, they can download this app and they can get the service. People who cannot afford a smartphone, they can actually dial a short code 10657 and they can avail the audio services. But imagine someone who needs a video consultancy, but he doesn't have a smartphone. That's where we came out with the Shukhi Sheba Kendra, as I mentioned. It's in Bengali. The meaning of it is Happiness Customer Service Center. So if you go to the next slide, what is this Shukhi Sheba Kendra? So it is like we tie up with the local pharmacies all over Bangladesh, and then these pharmacies are the centers. So any farmer who has got a skin disease using an insecticide can step into that pharmacy, and then we have the ambassadors working for us who are actually the owner of the pharmacy, and they are actually giving the end-to-end service. So if he needs an instant doctor, he can connect to that. He needs a specialized doctor, connect to that. He needs a laboratory test. In Bangladesh, in the remotest corner, the temperature maintenance is less than 80% of the specimen. We ensure the temperature maintenance over 90%. So the results is actually accurate. We also take care of the surgeries. So we ensure tying up with the hospitals who practice ethical, hygiene, and reasonable service provision. That's where that Trukhe ambassadors can send them to the right hospitals. So as I mentioned in my previous slide, so all these hospitals are connected through my hospital management system, and all these Shukhi Sheva Kendro, the Shukhi ambassador, they're connected with another app called Shukhi Expert app. That is how the ecosystem actually works. Let me show, seeing is believing. So if we go to the next slide, so this is actually the real picture. You can see the baby's feet is shown. This is a farmer who is getting the. Sorry, I'm actually in the middle of something. That's why there's so much sound. So this is a picture of a farmer, and I think this is a cab driver, or you can say the small people. And this is actually one of the old, one of the remotest corner of. So this is how it actually works, and the ambassadors, they actually give the service to anyone who are actually stepping in to these centers. Now, if you go to the next slide, what is the purpose of Kishaba Kendro? One is, if you go to the next slide, please. So when people go to these pharmacies, these pharmacy owners, they act like doctors. They always give them medicines without understanding. That is actually making the current scenario of Bangladesh on the antibiotic prone. As an example, the azithromycin, around 91% of the population in Bangladesh, they are prone to azithromycin. So we are trying to teach them, we are trying to guide them. Okay, instead of giving them an antibiotic without prescription and you're not authorized to that, why don't you use this platform and make sure that he sees a doctor, and that's how he gets the treatment. Then we also are ensuring, doing the specialized doctor, since we have limited doctor access, and we are also ensuring a proper EMR, and we are also doing the telehealth solution. So that is how we are absolutely taking care of the whole ecosystem through the Shukhi Seva Kendra. Going to the next slide. So this is where our scenario, we have got 5,000 centers. This is the spread, and these are actually the goal. We want to serve the bottom of the pyramid. in Bangladesh, around 50% people die without seeing a legitimate doctor. So we want to ensure that they see a doctor before they die when they're sick. Then specialist doctor calls. So if someone needs a specialist, he gets the specialist treatment. And then the surgery referral, we are getting very popular on the safer general surgery, mainly the laparoscopic surgery. Then the medical tourism, lab, and follow-up doctor calls. That means people travel to the city from village, and then they don't want to go back to the city again for the follow-up. So we want to ensure that they actually use this platform and ensure the follow-up call. I think the presentation slide is missing.
Yes, I will share my slide deck right now. 1 second.
In the meantime, Dr. Ahmed, would you check the chat? We will need to wrap up the presentation
I will.
when you
I will
can.
just finish. I will finish in a minute. Yeah. So
okay, great. We will still have the opportunity to discuss further in the Q&A session and then in the breakout room. So the content won't be lost. Thank you.
Okay.
Yeah,
just go to the last slide. Go to the next slide. So this is what the current scenario. We have got around 3 million app download with 1.8 million paid user. And in 8 months, we did 33,000 teleconsultation, 45,000 booking. So we are actually supporting the disparity. Like in rural area, there is only one medical professionals of 10,000 people. That's what we are actually serving. And we are actually our #1 app in Google Play for the last 6 months. Unfortunately, I have to leave because it's very much late at night, but I will leave my email address so you can post your questions and everything, and then I would be happy to answer. That's all from my side. Thank you for the opportunity.
Thank you. Sorry. Thank you very much. Sorry for the technical issue, everyone. We are now going to move into Dr. David Vanderpool's discussion. Thank you.
Hello, everyone. Thank you for having me today. Next slide, please. I'd like to talk about the communication and advocacy side of our funding challenges today. As we all know, we are experiencing funding challenges through the shutdown of the USAID. 3 changes that I would like to propose for this are making a stronger impact with return on investment stories, and also characterizing these stories according to your audience. And so thinking of people as donors, for instance, if it's government sources, then the taxpayers are our donors, getting a different message out than has been out previously. And so moving from the idea of aid into the idea of impact and return on investment. Secondly, I'd like to talk about equitable data use, making sure that we are achieving equity through our data and that we are addressing all populations that we serve. And then developing a local ownership through theory of change and local funding. Next slide, please. As we're talking about making a stronger impact and ROI stories, thinking about communication and advocacy, both to our funders and to our constituents. And so the constituents are often left out, I think. And so communicating impact to the constituents is important as well. So for instance, in our field of maternal and child health, looking at outcomes first, so maternal deaths being down, child death rates being down, and also looking at return on investment. Many studies have shown 7 to 1 improvements from an ROI standpoint. So for every dollar invested into a community, $7 are realized. And then looking at it from a concrete value standpoint, as we're communicating to donors, thinking about comparing it to something that is relevant to them as well. Next slide, please. The real world impact, we can tell stories that people understand, like the polio eradication stories. We can tell stories about clean water initiatives. These are stories that people can relate to. And I think as we attempt to change the tide of resistance against global health, we need to think about ways that we can impact people directly. Next slide, please. So as we are analyzing our data through electronic healthcare records and in our particular situation, making sure that equity is achieved. And so this can be had by looking at our data, but also providing data through surveys and understanding our constituents' needs and their viewpoints is very important. Then communicating this, their solutions that they derive as well. Next slide, please. Some of the actionable steps, like we mentioned, participatory surveys are very important. It gives power to our constituents, and it allows them to be a part of the solution. Two-way feedback mechanisms are very important, establishing the connection between the data that we derive and our constituents. And then making sure that we disaggregate frameworks. We use disaggregation frameworks to make sure equity is achieved. Next slide, please. The local theory of change is a very important concept, and this is one that could bear an entire seminar. But starting our local theory of change with our constituents at the outset, so bringing them into the arena very, very early, having them through conception and implementation and then conclusion. Involving the local community in funding models is a strategy, and then communicating that throughout the constituency as well as our donors. When we're looking for local health funding, community contributions are very helpful. Local philanthropic and business opportunities can be very helpful, as well as government co-funding. And these are all available to us as global health workers. Next slide, please. Let's go to the next slide now. Thank you. So in conclusion, as we're looking at the ability to communicate and advocate for global health, if we're thinking about advocating specifically for our constituents, I think it's very important that we keep them in mind as we're talking to government officials, as we're talking to foundations, as we're talking to local donors. Think about stories that convey return on investment and impact as you're discussing with these people. Think about equity evaluations at the constituent level to make sure that we're serving the people that we think we're serving. And then local steps toward local ownership of the programs. All three of these simple actions can contribute to an improvement in our communication and advocacy strategy in global health. Thank you very much.
Thank you so much, Dr. Vanderpool. We are going to now open up a question and answer period that's going to be run by Summer Hassan. So I will allow Summer to take it away.
Hello, everyone. Welcome back to our session. So currently we just heard from 4 of our presenters, and we've got a very nice variety of presentations going. So I see that there's a question in the Q&A function for Summer, not me, but I'll read the question. So it says, Dr. Marian, thanks. Quick question. On your second to last slide, it's not clear whether these 4 bullets will generate greater equity, sustainability, or how. In fact, likely that these trends will reduce equity. No? Question mark from Ted Nieres.
And unfortunately, Dr. Marion has had to step out. And so I would open this up to any one of the panelists who might have some input on this.
Could we see that second to last slide?
Yes, Summer, are you able to share that second to last slide from Dr. Marion's presentation?
Yes, just 1 second. Are you guys able to see that?
Yes.
Sure.
So maybe you could repeat the question again now that we have it in front of us.
Let me pull up the Q&A again. Yeah, so it said, quick question on the second to last slide. So whether these 4 bullet points will generate greater equity and sustainability, or how, in fact, it's likely that these trends will reduce the equity? Question mark.
So I would just take an initial stab at it. I think one of the issues is that often there's a counterbalance between equity and sustainability. So some things that we do for sustainability may or may not impact equity. And so with the two of them put together, for example, certainly moving away from aid and charity-based models with sustainable political commitment will lead to sustainability, and hopefully with sustainability also be more equitable. But if we talk about things like regionalism, for example, there it may not be quite as clear as states and regions grapple with improving their immediate situation. It may contribute to inequities. So I think there is some consideration about how we balance both sustainability with equity in terms of some of these mechanisms. That's what I would say. I don't know if any of my colleagues have anything to add to that.
Yeah, thank you, Colleen, Richard here. I was also thinking about that question and where we are with the current global health state. Those are really good compositions and points observed by Sama Marion. I think generally I could also add that to your observations, Colleen, that generally health systems are national responsibilities, and so national government could probably be better off investing at the national level. So away from aid, post-aid world, post-charity-based world might be more sustainable. The equity question could arise where you have differences between countries, some countries investing more than other countries. I'm aware here on the African continent that there had been previous agreements or consensus among governments, among ministers of health, to spend proportional percentages of their health budgets or their national budgets on health, 15%. Equally, consensus about spending 2% of the GDP on research. The Abuja Declaration, the Bamako Declaration about 20 years ago. And so perhaps when countries can reach a certain level of proportionate funding towards improving their health at the national level, it could generate, it could be based on, let's say, of course, financial or economic capability of the country that doesn't depend on aid. but also could be a better line addressing challenges in healthcare in that country. And perhaps national ownership can lead to more sustainability than, let's say, relying on global aid or charity-based models. So regionalism the same. If countries in the African region or South America or elsewhere have reached a consensus about where they ought to be and what they ought to do, I think leads to greater sustainability at the end. For equity questions, there could be a discussion there, but I don't think that charity-based models and global health aid, donor aid actually increases equity. I doubt that usually can happen. Thank you.
Thank you. Another question we had was, what strategies, and this goes to all the presenters, but what strategies are you or your organization using to navigate current geopolitical and funding uncertainties in global health? And I'll put that question in the chat.
I'd be glad to address that. We're a nonprofit organization, and so we raise all of our funds. We have not depended upon government funding in the past. And so we have our funding sources spread out among corporations and individuals. And so that's a big part of our funding model. And we think that it's been a very stable model. Some of the research suggests targeting a single model for sustainability. However, with the events of the last year, I think that choosing the right model becomes very important in that matrix. But for us, spreading out multiple funding sources through communities is our best way to work.
Thank you, David. Does anyone, do any of the other panelists want to?
And so this is not speaking from my organization, but more speaking from my region in terms of the Caribbean and health. And certainly cross-sector collaboration becomes more important than ever, especially in the context of small island states, where often what we do is at a smaller scale, and you can see great gains in efficiency and resources when entities work together and entities find more creative ways to share resources. So I would say that's certainly one approach.
Wonderful. Our next question is, what are your greatest challenges thus far, and your greatest success in the current geopolitical climate that you would like to highlight? So Carlene, I know that you've mentioned, being in the Caribbean and just the resiliency aspect of it. I'm sure there's a lot. But yeah, if anyone wants to jump in on that question, please feel free, and I'll put it in the chat.
Well, I can say definitely the greatest challenge is the same challenge we're all facing. I mean, we saw on this, our first presenter showed how the decrease in funding is happening across the board and from all sources. So I think that is definitely one of the challenges being faced, especially in programs that fill gaps with regards to existing systems. As has been said, really healthcare should be at the national or the government level. And so where there are gaps already in the systems that maybe were filled by donors that have now pulled back funding, it exposes those gaps. But that also means there's an opportunity, I think, to to create systems. I'm not saying it's easy to do, but I think there's an opportunity to create systems that allow for less of those gaps and for more sustainable access.
I agree with Carlene. I think her point is fantastic. Using local government sources as well as community sources, I think, is absolutely paramount. Our greatest success in this particular arena has been our nutrition program in Gaza, which we've continued since January of 2024. This has been a locally orchestrated program without obviously being insulated from any outside help. And so it's very amazing how well that has run in the midst of war.
That's wonderful insight. Richard, do you have anything to add? You're on mute.
Yes, sorry about that. Yeah, nothing really to add, but I think in context of the conversation about the value and role of technology, the scope of tech, I was curious to hear a little bit more from Dr. Siddiq with regard to the scope of technological innovation in addressing global health and questions about inefficiencies or even inequalities, because access to tech may vary depending on where one is. So if he's still on the call, I could maybe perhaps respond or address that question.
Unfortunately, there were some technology issues and he had an emergency, so he's no longer on the call, but we can send any questions directly to him.
All right. Thank you. Thank you.
I would want to say something in response to that note, though, with regards to innovation and technology. I really think that by design, when there's sort of, the new thing, the new innovation, the new technology, often we see that increase in inequity because, there's a new thing, it's difficult to reach, maybe it's expensive, etc. But I think use innovations and technologies that improve access do the opposite. So when we have innovations which by their nature improve access, so for example, telehealth options or innovations that allow reach, I think sometimes that can reduce the inequity gap. So it really depending on what kinds of innovations and technologies. And so we should really be investing in those ones that help us improve reach and increase resilience in terms of being able to adapt and to transform systems.
Yeah. Summer, as you're moderating this and with the speakers, panelists here, as well as everybody else here, thinking about, challenges, how to navigate the current geopolitical climate, and perhaps even what is the current state of global health, or in the next few years or so. We just celebrated the World AIDS Day on Monday. And I don't know where you are, but here in Kenya, for example, we already start to see increasing new cases relative to previous periods. So that in fact, while national incident cases have been going down precipitously over the last 15 years or so, this sort of almost a reversal, and I wonder how quickly this turn reversal can happen. But we also had today in the morning that the Gates Foundation released a report about trends in under 5 mortality rate, and it seems that for the first time in this century, in the last 20 years, we are seeing an increase in mortality in the 2024 data period relative to the previous years. So I think it seems as though these recent political and policy environments might bring a quick reversal in some gains in global health. Yeah.
Yeah.
Summer, if I could comment on that as well, I think that our success with technology has been dependent upon utilizing the expertise of local constituents. And so surveying their needs and then allowing them access to the development of the technology, I think is very, very important. And we've seen great success with that. And so our EHR, for instance, that we published in 2018, is a low bandwidth DHR. So it has a cache, so it doesn't require access to internet or cell service. And then it's very simple to use. It does not require a long lead up time to learn it. And so it's now deployed in 7 countries and doing extremely well cross-culturally. And so I think that those premises are very important in the success of technology.
Yeah, wow, that's amazing, David. I see that Dr. Emmanuel Ibarra said, thinking of innovations in technology and global health, we need to continue to apply technology to result in efficient and equitable global health services. So local communities being engaged on the needs of various communities, which is very true. As we continue this, I will pass the mic to Carrie to take us to our next segment.
Okay, great. Thank you, everyone. We are going to now move into specific breakout rooms where we can carry on additional discussions on each of these topics. And you can field questions to our speakers directly, or you can put them in the chat, but we will also have some prepared Mentimeter questions that you can participate in. So at this point, I will ask to open the breakout rooms and to allow us to send you all into the breakout sessions. Thank you, everyone. Sorry, everyone, we are back. Sounds like there was some really good discussion in there. So right now, what we're going to have some really short lightning round summaries from each of the rooms, and then we'll open it up for full Q&A. We have some Mentimeter questions that we'd like to discuss before we wrap up. So we can go ahead and start with room 1, which would be the room with Dr. Wamai and Dr. Marian. So Aisha, go ahead.
Yeah, thank you. So and within breakout room 1, we had a very interesting conversation when it came to health prioritization within national and regional frameworks. And with our discussion, I think that the main goal that we really hit home on was it's really essential to prioritize health within national frameworks, and that, the 15% budget allocation, that, that statistic that's always cited that is necessary for an effective health system is very essential when it comes to, the realm of global health governance. And also what was touched on by Dr. Summers' presentation on effective regional collaboration and, really facilitating, these learning and knowledge exchanges when it comes to, not only like global North and global South, but also these South-South learning exchanges to have a lot more effective advocacy that we're seeing on global health arena, such as the World Health Assembly, different ministerial meetings and engagements. So that is the discussion that we had. I hope I was able to summarize it to the best of my ability. If Dr. Wamai would like to add anything, please do go ahead.
Well, yeah, thank you. We had a small group of participants. We had a number of comments. I think we spent more time speaking about the first question. And it was valuable conversation. These are very, very valuable questions to discuss. But I give the comment that I gave in the general meeting, which is where we are now, where we have regions, so regionalism was spoken about by Summer Marian, and like in the African countries where countries have agreed what sort of level of spending they should put towards health in their countries, whether for research, for programming, that's already a path to sustainability, I think. The problem, of course, is always why have countries not met that target that they all agreed upon? I think there are challenges or problems with short-term memories because, after all, when governments agree this is where we ought to be, this is what we can get to, there is a path to get to that, but implementation is always a challenge. But also perhaps where there is no maybe accountability framework that they create for themselves to move forward to those targets that can also be sort of spell that this is not going to be achieved. And because the leader turnover is quite frequent in some countries, you have, like in the African region, you have coup d'etats. So when that happened, all of that historical memory and commitments get somehow thrown out the window. And so you have countries going back to the drawing board, not knowing particularly precisely where they are, what they ought to do. But I think I'm hopeful for this Accra reset on global health governance that was launched in New York by the Ghanaian president with representatives from other African, Caribbean, and European countries. That could be a goal that countries can get towards for sustainability. Yeah.
Thank you very much. Oriaku and Summer, can one of you please briefly summarize your room?
Yes, I'll go ahead. So in our room, we had a robust conversation. We had a couple of participants, and we're able to tackle all our 3 questions. On blended financing, we're able to know that pooling resources will help to cut down inequity in global health. And more so, funds and resources should be allocated to underserved populations like women and children. Then we now move forward to what are the practical steps to minimize dependence on donor, more so with the political and geopolitical issues that are happening right now in global health. One of our participants commented that if within in the global south, those countries can be able to have collaborations. He made a particular reference to maybe people that are expected to have chemotherapy, radiotherapy in Afghanistan, moving to Pakistan to be able to get this care. That will help to, we'll be able to build a sustainable models. These 2 countries, in as much as they are considered to be global south, they don't need to, rely so much on sorry, they don't need to rely so much on, donors from the global north to be able to do what they need to do. So if we can be able to access local resources, it will help to sustain and, move away from overdependence on donor. Then our last question, we were able to, go through it a little bit before we now came back to the main session, which accountability, make sure that there are accountability. People should be held responsible. People should be able to be transparent and accountable. That is the only way things can move and have impact on global health. Thank you. Dr. Carlin can still continue from where I said.
Thank you.
Dr. Carlin.
No, you did. That's okay. You did a good summary, I think. Thank you.
Thank you. So we'll move to room 3 summary, which I think is Anna. You can go ahead.
Yeah, thank you so much again, everybody who joined the session today and in our breakout room that focus on innovation and technology. We had a really nice, rich discussion and representation really from every corner of the world. So it was a really nice discussion. Although we ran out of time, but that's what happens when you have lots of good perspectives and engaging discussion. So just to summarize very quickly, so we discuss how so these examples of how innovation and technologies are really improving patient care and strengthening healthcare systems. And many times these innovations really come from low-income countries and come out of necessity because there are limited resources. And so often you have to come up with these really innovative solutions. And we discuss many different examples of how these technologies are being used. We also had speakers commenting on being aware of potential inequities and access to technologies. So this is always a concern. Also, a little of the warning not to have all the technologies and innovation just take over all of our systems. That humans really need to be centered and be the ones who are checking over the security of the data and use of data, or even the data that are being generated, right, by AI and technology. So those the humans still need to be the center and have that responsibility, have those parameters of safety, and be the ultimate decision makers. But all in all, we discussed and we are all excited about technology and how it can be catalyst for inclusive and people-centered progress in global health. And I don't know if Dr. Abara or others who were in the room would like to comment further. Yeah, I think that we can move to room number 4.
Yeah, room number 4, I think that's Tasha. Please go ahead.
Thanks, Carrie. So we had a rich conversation, and actually, we only stayed on question 1. That stemmed a lot of conversation. And what we did is we really took it down to some of the basic concepts when looking at how best to advocate and communicate, and focused on, how do we persuade governments to take care of their own, and how do you do that within the context of a corrupt government? Because of course we are seeing that there are these shifts from the new versus old paradigms of health systems, and what are people really focused on? Like, are they focused on the return on investment, or are they, and is that really in dollars and cents? Or is it really in health equity and taking care of their population? And there were a number of really rich ideas looking at how to influence governments and decision makers with the use of data. So it's not really the quantifying it, but it's really telling the stories of those individuals on the ground, how to navigate bureaucracy and governments, really making sure, who are the decision makers, who are the influencers who can make change and who can really, convey what is the overall influence of and intention of their governments when looking at making change. Of course, getting a sense of the rewards and whether one, I think it was David who mentioned, how are people, what are they driven by? Is it really by ego? Is it by change? Is it, are there ideologies that they're tapping into, right or wrong? How do we really, how do we drill down and understand the motivation? And then it's really building a strong value proposition to those who you are trying to influence, but also bringing that back to the people who are on the ground and who are providing you with that data, providing you with their stories, really trying to build the bridges with those who are local experts and working at the community level to reaffirm our commitment to building change and working with them. So, we probably could have had an entire day just to speak about this topic, and I look forward to hopefully continuing, this conversation in the new year at CUGH. But I invite David and the other participants who are part of our breakout to add if I overlooked anything.
Excellent summary.
Great, thank you. I was wondering if Aisha, if you could bring out the Mentimeter for our closing question before we wrap up, if that's possible.
Yes, of course. Let me just send in the participant link, and then I can share my screen as well.
Thank you.
This is the link, and I can share my screen.
So if participants, you can go to the Mentimeter question, and then do you think you could read the question? Because we are not, oh, there we go. Thank you.
Yes. Looking ahead, what operational changes are most critical for achieving lasting and equitable global health impact?
Thank you. I'm wondering if the panelists would like to share some thoughts as we're watching the Mentimeter participation come in. If maybe we could start with Dr. Radix, if you would like to share some thoughts on this.
Sure. I think definitely some of the things that are coming in speak to some of the conversations we had in our breakout session and to the general group. So shared, being clear on where we're going, having shared targets, especially when there are competing priorities happening both at national levels and at other levels, regional and otherwise. Having some clear measures around equity or equality, and again, the cross-sector collaboration, working together. I think those are some of the themes that we have here: accountability and collaboration.
Thank you. Dr. Vanderpool, would you like to briefly comment on this?
Yes, that sounds great. Yeah, I think, from my standpoint, communicating that the successes and the challenges to both our constituents and our donor base, and if that's U.S. government, then that means taxpayers. And so I think that we need to shore up our messaging in a way that's understandable and is relevant to our listeners and our donors. And so I think working on that as a global health entity is very, very important.
Thank you. We do have a second question in the Mentimeter if we wanted to shift to that quickly. Our second question is, what partnerships and governance shifts will be essential to sustain progress and strengthen global health systems going forward? I was wondering if Dr. Amin would like to think about this one and share briefly.
Yeah, that is absolutely right. The sustaining progress in global health will require strong multi-sectoral partnerships and modernized governance model that are agile, accountable, and equity focused. First, government-private sector partnership will be critical. to expand digital health infrastructure, strengthening the primary healthcare, and accelerate innovations such as telemedicine, AI-driven diagnostics, supply chain digitalizations. So academic industry need to collaborate as well. They can drive the implementation research, ensure evidence-based policies, and build a stronger surveillance system. Community-based and civil society partnership will be essential to maintain the trust, promote the health literacy, and ensure the culturally appropriate service delivery. And on governments, countries will need integrated, interoperable health information systems. Without that, it cannot get these things done in very well. So it's supported by the national digital health strategies with a strong regulatory framework for the data privacy, AI, and telehealth. And global governance must also shift towards more resilient, decentralized, and country-owned system where LMCIs have the strong decision-making power, strengthening regional collaboration. African CDC, and they will support the pool procurement, cross-border disease intelligence, and emergency preparedness as well. And finally, sustainable financing through the pooled risk mechanism, public-private financing, and long-term donor alignment will be essential to avoid the fragmented investments. And ultimately, durable progress depends on the trusted partnership, transparent governance, and a commitment to equity primary healthcare and digital transformations. And that ensuring the health systems are resilient, people-centric, patient-centric, and ready for future global health challenges. Thank you from my side.
Thank you so much. And just lastly, in about 2 minutes, Dr. Wamai, would you like to comment on this second question here before we turn it to Anna to wrap up?
Yes, sorry. Yeah, thank you. Indeed, yeah, this question about partnership and governance shift, I think it will be essential. I really appreciated the comments by Dr. Sama Marian about, the observation with regard to regionalism. So, for example, the African region or the region of the Americas, sort of moving towards addressing the burden of disease in those settings and then creating systems that can get us there. There was this big Lancet report of Global Health 2050 forecasting, for example, where countries could get by that time. It's a longer time horizon. We are coming to a period, I think, in the next year or so that we begin discussing the next set of goals beyond 2030. So I think, those environments and arenas where conversations for the next set of global goals beyond 2030 and what kind of governance structure may be needed at that point in time, and for getting us to 2050, perhaps even at that time horizon, I think it will be really useful. This is sort of a period to reset at the country level with the current geopolitics with global health, as Dr. Marian showed us the statistics about where we are, not just the US reducing its financing, but also, and then where the financing, which regions are more affected by financing. So, and the only way I think is to move towards a sort of a decolonized state of global health by, sort of regionalism, countries taking ownership. And I really appreciated this effort by the Ghanaian leader, Dr. Mahama, for launching the Accra Reset in Global Health Governance in New York, and look forward to what might be coming in the next year with regard to a direction towards a new global health environment that can get us to a sustainable model for financing health at the national level that can improve health of all populations across the world without increased reliance or getting back to reliance in donor financing for health post the political environment. That may not change in sort of the time horizon for leadership turnover in the US or whatever else those turnovers may happen. But I think it is sort of very good poignant moment for countries to pivot towards national efforts, regional efforts, and I think that's where we ought to be moving towards. Thank you.
Thank you so much. And thank you, Aisha, for sharing the Mentimeter. If we could go back to the slides for Anna to wrap up our session. Thank you, everyone.
Yeah, while we are waiting on the slides, just two more slides. Really, I would like to take this opportunity to thank everybody who attended this session today. I would like to thank our participants for the engaging discussion, our speakers and panelists, the discussion leaders, moderators, CUGH leadership. And I would like to thank all of the members of our wonderful committee, CUGH Global Health Operations Committee, for putting this session together. And really, 2 hours just really flew by. Yes, can we get the slides back? Sorry. Okay. Yeah. Thank you. With that, so we had lots of great ideas, lots of great perspectives and discussions, and we would like to invite you to the CUGH 2026 with the theme "The Future of Global Health," which will take place in April 2026 in Washington, D.C. Our wonderful committee is organizing 2 sessions for you. The pre-conference workshop from silos to synergy, cross-sector collaboration shaping the next decade of global health operations. And then we will have the panel on financing the future of global health, pathways to sustainability. Okay, next slide. So please, if you have any additional questions, comments, or the interest in our committee membership or just general feedback, these are our emails for Richard and myself, who serve as co-chairs of the CUGH Global Health Operations Committee. We can also connect you to our speakers and other committee members. Again, thank you so much for your time, for your thoughtful participation and engagement, and we hope to see many of you at CUGH 2026 in April in Washington, D.C. Thank you again.
Thank you so much. Thank you.